Good morning to everyone. Myself, Dr. Kamali, doing first year post graduation in the Department of Conservative Dentistry and Endodontics at Sri Balaji Dental College and Hospital. Today, I'm going to talk about anesthesia in endodontics. These are the contents I'm going to cover. So, introduction. Anesthesia, it is widely used method of pain control. You can give a painless treatment and also a comfort to the patient by giving anesthesia. History of anesthesia. In 1869, man introduced cocaine, which was first local anesthetic agent. It is produced from the leaves of coca tree. Then Carl Koller in 1884 said anesthetic action was demonstrated. Heon in 1905 described procaine, which was first effective and widely used synthetic local anesthetic. Bibberfield said anesthetic properties were identified. Braun said local anesthetic agent was introduced into clinical practice. Anesthesia, there can be local anesthesia, regional and general anesthesia. Under local anesthesia, you have topical and infiltration. Under regional, you have peripheral nerve block, epidural, spinal and intravenous. Under general anesthesia, you have topical intravenous anesthesia and topical inhalation anesthesia. Definition of local anesthesia, it is defined as transient and completely reversible loss of sensation in a circumscribed area of a body caused by depression of excitation nerve endings or inhibition of conduction process in peripheral nerves. Loss of sensation without inducing loss of consciousness by Stanley F. Melamed, 1980. Properties of local anesthesia, it should not be irritating to tissue to which it is applied. It should not cause any permanent alteration of nerve structure. Its systemic toxicity should be low. Time of onset of anesthesia should be short. It should be effective regardless of whether it is injected into a tissue or applied locally to mucous membranes. Duration of action should be long enough to permit the completion of procedure. By Hisham L. Harvey. Action potential, sodium and potassium channels first is closed, which leads to fiber stimulated. Sodium channels open, then sodium enter the cell. Potential rises, then cell undergoes depolarization. Sodium channel will get closed, then which leads to potassium channel opens. Potassium exits the cell. Potassium falling, which leads to fiber repolarize. Sodium and potassium channels closed. Sodium and potassium pump restores balance. Depolarization and repolarization, sodium pump, where energy comes from oxidative metabolism of ATP. Depolarization takes place in 0.3 millisecond and repolarization in 0.7 millisecond. So entire process requires 1 microsecond. Theories of mechanism of action of local anesthetic. There are 5 theories, that is calcium displacement theory, acetylcholine theory, surface charge or repulsion theory, membrane expansion theory, specific receptor theory. Local anesthetic agents, the ingredients are local anesthetic agent with a xylocaine or lidocaine 2%, vasoconstrictor adrenaline in the ratio of 1 is to 80,000, reducing it in sodium metabisulfate, preservative methylparaben, fungicide thymol, vehicle distilled water, sodium chloride. Classification of local anesthetics mainly classified as esters and amides. Under esters, you have esters of benzoic acid and esters of parabenzoic acid. Under esters of benzoic acid, you have cocaine, butadiene, piperocaine, benzocaine, tetracaine. Under para-aminobenzoic acid, procaine, chloroprocaine, propoxycaine. Amides, you have ropivacaine, napivacaine, articaine, bupivacaine, etidocaine, dibucaine, lidocaine, prilocaine, melamine. Distribution, once absorbed in the bloodstream, local anesthetics are distributed throughout the body to all tissues. Highly perfused organs such as brain, head, liver, kidney, lungs have higher blood levels of anesthetic than do less higher perfused organs. The blood level is influenced by rate of absorption into the bloodstream, rate of distribution of the agent from the vascular compartment to the tissues, and elimination of drug to metabolic and excretic pathways. Metabolism, that is biotransformation, ester local anesthetics, whereas chloroprocaine the most rapidly hydrolyzed, but it is least toxic. Tetracaine hydrolyzed 16 times more slowly than chloroprocaine, hence it has the greatest potential toxicity. Amide local anesthetics, the metabolism of amide local anesthetics is more complicated than esters. The primary site of biotransformation of amide drugs is liver. Entire metabolic process occurs in the liver for lidocaine, articaine, etidocaine, and bupivacaine other amides. Excretion, kidneys are the primary excretory organs for both the local anesthetic and its metabolites. Percentage of given dose of local anesthetic drug is excreted unchanged in the urine. Esters appear in only very small concentration as parent compound in urine. Procaine appears in the urine as PABA, 90% and 2% unchanged. 10% of cocaine dose is found in the urine unchanged. Amides are present in the urine as a parent compound in a greater percentage than the esters. Problem solving. So how many milligram of mepivacaine are contained within 2 cartridge of mepivacaine 3%? The answer is 108 mg. How much of lidocaine in a cartridge of lidocaine 2% with epinephrine 1 is to 1 lakh? How much epinephrine? 36 milligram of lidocaine cartridge and 0.018 milligram epinephrine per cartridge. Armamentarium syringe types available in dentistry, non-disposable syringes. Under that you have breech loading, uh, plastic cartridge type aspirating, breech loading metallic cartridge type aspirating, breech loading metallic cartridge type self aspirating. Then pressure syringe for periodontal ligament, jet injector, needleless syringe. Then you have disposable syringes, safety syringes, computer controlled local anesthetic leeway systems. So breech loading plastic cartridge tube aspirating, a plastic reusable dental aspirating syringe is available that is both autoclavable and chemically sterilizable. With the proper care and handling, this syringe may be used for multiple anesthetic administration before it is discarded. Advantages are it is lightweight, provides better feel during injection, cartridge is visible, aspiration with one hand, rust resistant, long lasting with proper maintenance, and lower cost. Disadvantage size may be too big for small operators and possibility of infection with improper care. Breech loading metallic cartridge type aspirating. The term breech loading implies that the cartridge is inserted into the syringe from the side of the barrel of the syringe. So the advantages is visible cartridge, aspiration with one hand, autoclavable, rust resistant, long lasting with proper maintenance. Disadvantages weight because it is heavier than plastic syringe. Syringe may be too big for small operators and possibility of infection with improper care. Breech loading metallic cartridge type self-aspirating. So the incidence of positive aspiration may be as high as 10 to 15% with some injection techniques. These syringes use the elasticity of rubber diaphragm in the anesthetic cartridge to obtain the necessary negative pressure for aspiration. Advantages, disadvantages. Advantage cartridge visible, easier to aspire with small ants, autoclavable, rust resistant, long lasting with proper maintenance. Piston is scored. Disadvantages, weight, feeling of insecurity for doctors. Fingers must be moved from thumb ring to thumb disc to aspire, possibility of infection with improper care. Pressure syringes. Pressure syringes brought about a renewed interest in the periodontal ligament injection, also known as intraligamentary injection, helped make it possible to achieve more reliable pulpal anesthesia of one isolated day. Advantages and disadvantages. Advantages, you have measured dose, overcomes tissue resistance, non-threatening and cartridge protected. Disadvantages, cost and threatening. Jet or needleless injector by Figge and Scherer. Margate is the first report of the use of jet injection in dentistry was published. So jet injection is based on the principle that liquids force through very small opening called jets at very high pressure can penetrate intact skin or mucous membrane. Advantages, it does not require use of needle, delivers very small volume of local anesthetic and use in topical anesthetics. Disadvantages, inadequate for pulpal anesthesia or for regional block, cost and may damage your periodontal tissues. Safety syringes, the Ultra Safety Plus XL aspirating syringe system contains a syringe body assembly and a plunger assembly. Once the syringe is properly assembled and the injection administered, the syringe may be made safe with one hand by gently moving the index and middle fingers against the front collar of the guard. Advantages, sterile until open, lightweight and cost. Disadvantages, more expensive than reusable syringe, may feel awkward to first time user. Disposable syringes. A syringe is a simple pump consisting of plunger that fits tightly in a tube to assist pushing liquids or solids into an object either through a needle, tubing or a nozzle. Advantages, disposable single use, sterile until open, lightweight. Disadvantages, does not accept pre-filled dental cartridges, aspiration difficulty. Techniques of maxillary anesthesia. You have posterior superior alveolar nerve block, middle superior alveolar nerve block, anterior superior alveolar nerve block, anterior middle superior alveolar nerve block. Maxillary nerve block, nasopalatal nerve block, greater palatal nerve block. So types of anesthetic injection, you have field block and local infiltration. Posterior superior alveolar nerve block. Other names you have tuberosity block is zygomatic block. Areas anesthetized are pulps of maxillary third, second, and first molar except mesiobuccal root of first molar. Buccal periosteum and bone overlying the teeth. Indications where supraperiosteal injections contraindicated or ineffective. Advantages: atraumatic eye success rate, minimum number of necessary injection. Disadvantages: risk of hematoma, no bony landmarks during insertion. Secondary injection necessary for first molar. Orientation of bevel towards the bone. Then depth of insertion is 16 mm. Position: left posterior superior alveolar nerve 10 o'clock position, right posterior superior alveolar nerve 8 o'clock position. Middle superior alveolar nerve block. Areas anesthetized are pulps of maxillary first and second premolars, buccal periodontal tissues. Indication where anterior superior alveolar nerve block fails to provide pulpal anesthesia for maxillary premolars alone. Contraindication: infection or inflammation at the site of injection. Technique: area of insertion, height of mucobuccal fold above the second premolar, target area maxillary bone above the maxillary second premolar. For a middle superior alveolar nerve block, right-handed administrator should face the patient directly from 10 o'clock position. For the left middle superior alveolar nerve block, left-handed administrator should face the patient from 8 to 9 o'clock position. Thank you.